kind of a bright light and it's hard to see people, but it's good to be here. And for those of you that are not from Boston, welcome. I hope you've had a chance to see some of our city. Before we get started, I'd like to thank Adam and Harry and the organization for inviting us to take part in this. And I'd also like to introduce my colleague, Dr. Claire Kruger. I think she's back over in this corner. Claire, if you'd stand up. Claire's the co-author on this paper, and as you can see, she's much more attractive than I am, but I would request that you refocus your attention on the stage and not on her while I'm giving this talk. The other thing is, I don't know if Tom is still here or not, but I have to apologize to him because he said something about scientists and PowerPoints, and that's all you're going to see for the next few minutes, a number of PowerPoints. What we are going to do in the next few minutes is to talk about the challenges for establishing an upper intake level for the omega-3 fatty acids. And as was mentioned at the request of GOED, Spirex did prepare a weight of the evidence, hazard identification, and characterization for the N3 fatty acids, looking at DHA, EPA, and DPA in general. And as was mentioned earlier, the DPAs are, we look for them, but there's just a lot of information out there regarding them. And we also did it with specific reference to the fish and algal-derived oils containing 20% or more of EPA plus DHA plus DPA, either as the native triacylglycerol or the reconstituted tags or the ethyl esters. What we're going to be covering is a little background information, what's been done by a number of authoritative bodies, what was done by Spirex, and then after my colleague from the Netherlands comes up and talks, we'll have our discussion about things that need to be done as we move forward. Just a little background so that we're sure that everybody is on the same platform. I want to give you some definitions. Most of you probably know this, but as a college professor, we always assume that there's one person in the audience that may not have all of the information, so we'll lay the background. The acceptable intake is that amount that we would like to have present in order to take care of the beneficial effects. The upper intake level is the level that we don't want to exceed. And that's what we're talking about here, is how do we develop this upper intake level? It's there, but as I'm going to try to show you, we haven't yet discovered exactly where it is. So as we think about this and look at the very traditional nutrition function risk curve, you can see that it has two ends to it. On the one side, we have that risk of not having enough of the material. On the other side, the risk of having too much of the material. The AI or the upper limit. And just to give you a very simple example is selenium. We have a recommended level of about 55 micrograms per day for adults, and an upper limit in the neighborhood of 400 micrograms per day for adults. So we want a certain amount of the material to prevent some of the things that selenium is involved in as far as its activity in enzymes, but we don't want to exceed that 400 micrograms per day, because if we do, we run into the risk of getting ourselves into silicosis, which is a disease, poisoning effect as the outcome of too much of this particular material. We want to be in that optimal range in between the AI and the UL. To define these terms, the hazard identification is when we are looking for the innate toxicity, the data that will help us identify the types of health effects that are related to the material that we have under concern. Hazard characterization is the way that the Europeans define what we in the U.S. call the dose response, and that's really more the quantitative. Does it cause an effect, and at what level do we see those adverse effects? And we can put this together very simply by identifying the hazard on the one hand and then looking at the characterization of the dose response on the other hand, and we need all of that information to gain the upper limit. And that's where the real problem lies as far as these long-chain fatty acids are concerned. It's that dose response, that hazard characterization that's very difficult to ferret out of the data that we've looked at. Hazard identification requires good data evaluation, interpretation, taking all of the information that you have from a weight of evidence standpoint, and being able to say, does this relate to human health? In the studies, if we can have human data, that's the way we would like to go, and we did limit ourselves to human data in this evaluation. Intervention trials are the preferred, and when we began to look at the clinical evidence, these randomized controlled intervention trials are the ones that we would really like to see, particularly if they have endpoints that include the adverse effects as well as the beneficial effects. Well, what's been done? A number of regulatory and authoritative bodies have looked at the data that's out there and made some comments or recommendations. And this was done in response to consumer interest in the consumption of these N3 fatty acids to derive health effects. And out of that, we're looking for that tolerable upper intake level for these N3 fatty acids. There's a laundry list of potential adverse effects. You're probably familiar with all of these. I'm not going to go through them, but you can see them. Increased incidence of bleeding down to the effects on early childhood development. Out of all of these authoritative bodies, we really have coming inconsistent or missing guidance on what that upper level for these fatty acids is or should be. Now remember I said it's there, we just haven't yet found what that point is, at least based on what these bodies have done. Now I'm going to go through four of them. The U.S. Food and Drug Administration, the U.S. Institute of Medicine, a German report from their risk assessment, and the Norwegian report. Just to give you briefly the information that has been brought forth. In the U.S., there's a GRAS document that states that 3 grams a day are safe for the general population of this particular oil. This ruling was based on fish oils, on bleeding time, glycemic control, and low-density lipoproteins. They were relatively limited in the amount of information that they had, and as you can see, this is 1997, and it took place a while back. The Institute of Medicine, in its 2002 report, looked at high intakes of the N3 fatty acids, particularly EPA and DHA, and they suggested that there's a potential for impaired immune response and that potential for excessive bleeding. In both cases, in the first case, most of the information was in vitro, difficult to translate that to in vivo studies. And in the second case, they said that the information is lacking to conclude that these two N fatty acids were the sole basis for these observations. So their overall conclusion was that there was insufficient evidence to set a UL. The German Federal Institute for Risk Assessment looked at some data, and they came up with a recommendation that no more than 1.5 grams per day of the N3 PUFAs from all sources. And they also said that they would recommend that they not be put into water-based or materials that didn't contain fat, such as water-based beverages. Their criteria for coming up with this 1.5 grams was based on increased bleeding tendency in a study that was published by Clark in 1990 of 11 adolescents who had taken up to 1.5 grams of the N3 fatty acids. There was a single individual out of 11 that had prolonged bleeding times, about 9 minutes versus the normal of 3 to 5. Two of the subjects, one of which was on aspirin, experienced nosebleeds with a moderate prolonged bleeding time. I think the key here is that when you start looking at other parameters, prothrombin, partial thromboplastin times, and platelet counts, these were all normal in these studies. The Norwegian Food Safety Authority had their Scientific Committee for Food Safety, the VKM, look at both the positive and the negative human effects using the criteria that I've listed below for the negative effects. And their general conclusion was that it was not possible to set an upper limit for these two fatty acids based on the information that they looked at because, again, it's not the hazard part, identification, but it's that hazard characterization, dose response that prevented them also from coming up with an upper limit. So if we put all of our cards on the table, all of the values that we have the FDA, the IOM, the BR, and the VKM. Two of these, the IOM and the Norwegian group, said there was insufficient data to set an upper limit. The FDA, on their relatively limited database, came up with an ADI of 3 grams per day for this particular Mehinden oil, and then the Germans have their number of 1.5 grams of the N3 PUFAs per day from all sources. So that's the information that we begin with when SpearX was asked to look at this data again. And what SpearX did was to focus on the clinical studies supported by review papers and the various meta-analyses that are out there. The methodology that was used in retrieving and evaluating, beginning with the German literature, the Norwegian literature, and then picking up information from the literature from 2008 to 2012 in both healthy and health-compromised individuals, looking again at these same endpoints that we've been talking about. And then as each of these papers were reviewed, to look at the methodology deficiencies and confounders that might have been present in these various studies. These are the search strategy terms that were used. And if you look over onto your right, you see the safety endpoints that were added to all of these various search strategy terms that were used. in searching the literature from 2008 to 2012. Each study was given a thorough evaluation looking at the objectives, the study design. Was it an appropriate design? What was the study population? How large was it? Again, looking at those endpoints and what were the outcomes related to those endpoints? What were the exposures? Trying to get a handle on that dose response. What about other medications or medications that were being taken? What were the potential confounders that were there that could have affected the outcome of the study? To look at the effects and no effect levels, again, trying to focus on that dose response, and then discussing and reaching a conclusion as to whether or not the result that the author had presented was really what was reflected in the data, and where possible, to determine the amounts of each of these N3 fatty acids and the form that it happened to be in. Most often, these were not present in the studies. Individual endpoints. We're going to start with blood lipids. And what I've done on each of these slides is, in parentheses, you'll see the total number of studies that were evaluated. Total cholesterol, 31, triglycerides, 33, LDH cholesterol, 29, LDL cholesterol, 29, and oxidative stress, lipid peroxidation, 30 studies. Studies that were excluded were those studies that did not have a baseline to measure or compare against the final result. And the reason we did that is that we were not convinced that there was a control oil that could be used that wouldn't have adverse effects on these blood lipids. Now, the next several slides are very busy. There's a lot of information, but the thing that you really want to look at is what's in red. Because I think you're going to see that, as has already been pointed out, that the data bounce around quite a bit. Sometimes there's an increase, sometimes a decrease, other times no effect. And we've also broken this down into healthy populations versus health compromised populations. So here's just an example of 17 studies, and we put the highest level up to, and you can see with total cholesterol, 3 studies, there was an increase. 1 study, there was a reduction. 13, no effect. Moving on, in health compromised, again you see increase, reduction, predominantly no effect. Triglycerides, we begin to see kind of a pattern here, particularly when we get to our compromised. Decrease in 9, no effect in 9. The compromised population, decrease in 13, no effect in 3. If we go to LDL, same type of thing. Most often in healthy populations, no effect. Health compromised, there was a little bigger split here, some increase, 1 decreased, 7 no effect. HDL, same type of data bouncing around in these studies. Health compromised, increased, decreased, no effect, 4, 1, and 9. There were 27 studies that were looked at that had to do with oxidative stress and lipid peroxidation. A lot of the endpoints that were looked at here were in vitro, or the actual determination was ex vivo, and so it was very difficult to compare those to what would take place in vivo. But overall, there was a lack of validation of these studies, which made it very difficult to interpret the results as they pertain to hazard identification from ingestion of the N3 fatty acids. There were modest increases in LDL and HDL cholesterol and decreases in triglycerides when you look at it in the broadest sense. The clinical implications of the possible minor increases in LDL cholesterol within the context of the overall lipid profile is really unknown. But if you look at a lipid profile after consuming these N3 fatty acids, that includes a shift to an increase in HDL and a reduction in triglycerides, that may be a favorable outcome. Now, bleeding parameters. N3 fatty acids are reported to inhibit platelet aggregation, reduce blood viscosity, and to increase the risk of bleeding. 23 studies were looked at here, 2 in healthy populations and 21 in health-compromised populations. And you can see the endpoints that were looked at. 7 studies, up to 21.3 grams of the N3 fatty acids. There was no prolonged bleeding times versus baseline. 2 studies, up to 6.9. Significant prolongation of bleeding time versus the baseline, but again, they were within the normal range and they didn't produce any clinical significant bleeding episode. 2 studies in adolescents and in adults showed an increased bleeding that exceeded the normal range in 3 of 11 children. But remember, there were concomitant use of drugs here, and the increase to the baseline really had no clinical significance at the time of surgery or after surgery when compared with matched controls. There was no or inconsistent effects on all of the parameters that were looked at. Then we looked at several reviews which basically, using large numbers of people, the Cochrane review, no significant difference in bleeding times, the Harrison 207 review of over 4,000 patients, no increased risk for adverse bleeding episodes, the Salisbury 2012, 15,000 patients, and again, within these time frames up to and above 8%, there was no difference in bleeding times. And Byers in 2007, in his review, concluded that even in the presence of drugs such as aspirin or Coumadin, warfarin, that increase bleeding time, the consumption of omega-3s or the N-fatty 3 intake didn't affect the bleeding times. So we can come out with an overall conclusion that the effects that we're seeing are rare, inconsistent, not associated with a dose response, and not linked to bleeding complications or clinically adverse outcomes. Confounding conditions played a role here. Hereditary, we saw, I think, from France, one of the meta-analyses that showed depending on the part of the world that you're in, you may have different effects. These polymorphisms can play an effect here. The background dietary levels of the N-fatty acids are really not well described, and there was this confounding medication that we've already talked about. The immune system. 55 papers, including healthy and compromised individuals. We excluded cancer, individuals that were on hemodialysis, and studies that did not have this baseline control data. Consumption of up to 2.1 grams of EPA and 1.1 gram of DHA per day did not appear to perturb the immune homeostasis or suppress the immune response. However, many of these studies were based on ex vivo analyses. There were 2 studies that suggested favorable effects on infection. And overall, there didn't appear to be any induction of the inflammatory response up to 3.8 grams EPA and 2 grams DHA in healthy individuals. The caveats are that many of these studies relied on ex vivo analysis. They were small in size, limited number of markers were looked at, and the amounts of the material that was administered varied greatly. Diabetes, 28 studies. We excluded non-diabetic patients. The use of up to 3 grams didn't appear to have an effect on glucose control or insulin response. Less than 11 grams did not reproducibly impair glucose or control or insulin response. And the 9 meta-analyses that we looked at, again, 10 grams of these N3 fatty acids didn't appear to have an effect on fasting glucose, HbA1c, or plasma insulin or insulin resistance. Infant and childhood growth, 36 studies were there, randomized placebo-controlled clinical trials of DHA, supplementations to mothers, to term infants or preterm infants. Studies that were excluded were those that didn't measure the head diameter, body weight, or body length, and there were some efficacy studies that showed effects improving neurological development that were also excluded. Supplementation to mothers up to 4 grams of fish oil during pregnancy, no significant adverse effects on these measurements in offsprings up to 7 years, and no significant difference in blood pressure, heart rate, or pulse wave velocity, the aorta, the flexibility in the aortic artery. Supplementation of nursing mothers up to about 1% produced no adverse effect on the growth in their children. No adverse effects from DHA supplementation in term infants, preterm infants, given roughly 1% of this supplementation. Our conclusion that there were no, or the lack of these adverse effects for pregnant and nursing mothers, term and preterm infants, is consistent with a number of regulatory bodies and authoritative agents, both in the U.S. And the European Union. GI, 29 studies. We excluded diabetic patients here. These disturbances were primarily associated with oily substances, and there was really no way to specifically associate them with the N3 fatty acids. 19 studies in both healthy and health-compromised individuals evaluated the effect of these N3 fatty acids up to 6 grams a day for 2 years, and they were not associated with adverse GI disturbance, and there was no apparent difference between the ethyl ester or the TAG form. 17 studies reported no association of N3 fatty acids with adverse GI effects up to 18 grams per day, but the lack of control limits the conclusions that can be drawn here. Bringing this all together, taking a weight of evidence approach to the hazard identification and the hazard characterization, looking at these endpoints that had been identified, we were not able to identify studies that were appropriate to define the specific intake level or intake response relationship that could be used to derive a UL for these effects. And these conclusions are basically the same that the IOM and the Norwegians concluded. And that's the last slide. Thank you very much for your time, and my colleague from Norway will be here shortly.
Thank you very much, Wally.